Welcome back to Hypertension Unlocked. In this video, we are covering part A, primary hypertension. Integrating the clinical and radiological approach we introduced in our jaundice series. Let's start with the basics. Hypertension is a sustained elevation of blood pressure above normal. According to the 2025 AHA guidelines, normal blood pressure is below 120/80. Elevated is 120 to 129 over less than 80. Stage 1 hypertension is 130 to 139 over 80 to 89. And stage 2 is 140 over 90 or higher. But here's something important. You should never diagnose hypertension of a single reading. Diagnosis requires the average of at least 2 readings taken on at least 2 separate occasions. This reduces error from anxiety, recent activity, or poor technique, and sets the foundation for accurate management. Once you have elevated readings, how do you confirm they are real? There are 3 settings to measure blood pressure in: office, BP taken in a clinical setting, home blood pressure monitoring, where the patient measures it themselves, and ambulatory blood pressure monitoring, worn continuously over 24 hours. How does the office methods reduce anxiety-related error and are recommended to confirm the diagnosis before starting treatment? This brings us to white coat hypertension, where office BP is 130/80 or higher, but home or ambulatory readings are below 130/80. The patient only appears hypertensive in the clinic, likely due to anxiety in that setting. But don't dismiss it as harmless. It still needs long-term monitoring. The opposite pattern is masked hypertension, below 130/80, but home or ambulatory reading are 130/80 or higher. This is easily missed if you rely on office readings alone, and it carries a similar cardiovascular risk to sustained hypertension. It's exactly why out-of-office monitoring matters. Getting an accurate reading starts before the cuff goes on. The patient should rest quietly for 5 minutes, avoid caffeine, exercise, or smoking for 30 minutes prior, and empty the bladder beforehand. They should be seated with the back supported, feet flat on the floor, legs uncrossed, and arm supported at heart level. Technique matters too. Use the correct cuff size. The bladder should cover at least 80% of the arm. Place it on bare skin, not over clothing. No talking during the measurement. Take at least 2 readings, 1 minute apart, and then average them. On the first visit, check both arms. Before we even get to the physical exam, history matters. On the modifiable side, ask about smoking, excess alcohol intake, high salt intake, obesity, excessive stress, and a sedentary lifestyle. All of these directly raise blood pressure risk. Then there's family history of hypertension and increasing age, both non-modifiable. Ask about sleep patterns too, and screen for obstructive sleep apnea. Always check for known cardiovascular disease, diabetes, or chronic kidney disease. This history sets the stage for how you'll approach risk-based management. Here's the thing about primary hypertension. It's frequently asymptomatic. Most cases are found incidentally on a routine checkup. That's exactly why it's earned the name the silent killer. When symptoms do appear, they are usually non-specific and may point to how severe the hypertension is or early organ involvement. When symptoms do occur, look for headache often at the back of the head, worse in the morning, dizziness or lightheadedness, nosebleeds, subconjunctival hemorrhage, chest pain, breathlessness, and blurring of vision or double vision. Hypertension falls into two categories: primary or essential hypertension has no single identifiable cause and accounts for roughly 90 to 95% of adult cases. It's often an incidental finding. Secondary hypertension, on the other hand, has an identifiable underlying cause, and its symptoms vary depending on what that causes. We'll explore each of these causes in depth in part B of the series. On examination, hypertension is often completely normal to look at, no visible signs at all. That's part of why it is so silent. The elevated blood pressure reading may be only the clue you get. And remember, the absence of signs does not mean the absence of risk. When end organ damage has occurred, cardiac signs may include a displaced apex beat from left ventricular hypertrophy, an S4 gallop on auscultation, raised JVP, and peripheral edema. If heart failure has developed, these are all reflecting chronic pressure overload on the heart. On the eyes, look for hypertensive retinopathy, arteriolar narrowing, AV nicking, flame-shaped hemorrhages, cortical spots, and papilledema, which signals malignant hypertension. These are picked up on fundus examination. For signs of chronic kidney disease, look for pallor, edema, and palpable kidneys, which should raise suspicion for polycystic kidney disease. Focal neurological deficits suggesting stroke, and altered mental status, which points to hypertensive encephalopathy. Note: vascular signs pointing to secondary causes, radiofemoral delay, bruit, diminished pulses, are intentionally excluded here and covered in Part B alongside coarctation of the aorta and vasculitis. Every newly diagnosed patient needs a baseline laboratory panel: renal function test, electrolytes, a lipid profile, fasting glucose or HbA1c, and urine analysis. And under the 2025 guideline update, urine albumin creatinine ratio testing is now mandatory for every hypertensive patient. Previously, it was only optional. Why do these tests matter? They establish baseline cardiovascular risk, detect early kidney involvement, screen for coexisting metabolic risk factors, and guide whether further targeted testing is needed. This is done in every newly diagnosed patient, regardless of whether they have symptoms or not. Beyond the baseline panel, not every patient needs every test. Further investigations are guided by the signs and symptoms you actually find. The goal is to detect damage that's already present, not to screen blindly. This keeps the workup efficient and clinically relevant. If you suspect stroke, order a CT or MRI scan. If you suspect coronary artery disease, get an ECG, echocardiogram, and troponin. If retinopathy is seen on exam, arrange fundus photography. And if chronic kidney disease is suspected, order a renal ultrasound. Each finding drives its own targeted workup. So, where does imaging fit in for primary hypertension? Very little, actually. The basic workup is unremarkable. No routine imaging is required. Imaging is mainly reserved to rule out secondary causes, and it's only ordered when history, signs, or labs raise suspicion. So, when should you suspect a secondary cause? Think about early onset in young patient or late onset in an elderly one. Resistant hypertension despite treatment, sudden worsening of previously controlled blood pressure, severe hypertension, stage 2, or a hypertensive emergency, or signs and symptoms pointing to a specific organ system. In part B, we are diving into secondary hypertension in depth. Renal causes like renal artery stenosis, chronic kidney disease, and polycystic kidney disease. Endocrine causes like Conn syndrome, Cushing syndrome, and pheochromocytoma. Vascular causes like coarctation of the aorta and vasculitis, and other causes like obstructive sleep apnea, drug-induced hypertension, and neurogenic hypertension. For each one, we'll integrate the clinical and radiological approach, symptoms, signs, laboratory findings, and imaging. See you in part B. Thank you for watching. Follow and subscribe at Funky's Medical Corner for integrated approach of clinical medicine with radiological imaging.